So I have a few slides. As you remember, you guys are closer to this time of being a medical student. Wherever there is pass, it has to be what? Yes, it has to be removed. So the management of Empyema thoracis is basically business of the surgeon. However, Dr. Rajan left that table. Simple parapneumonic effusion, complicated, and the frank pass. The first two, we can actually deal with them medically. So, for the Empyema itself, our role as physicians is to guide these surgeons on how to choose antibiotics. As you know, physicians, we sit at the top of the food chain. So that's our role, is to provide some guidance. But before I do that, Dr. Rajani has gone through this. The question you ask yourselves, who gets Empyema? And how does an Empyema patient come to the clinic? And that has been discussed. We know that actually most people who have a bacterial pneumonia or any pneumonia for that sort get some form of effusion. Because when there is inflammation, the lung swells. When it swells, it presses on the pleura and there is some exudation. In some people it is little, in other people it is much. So up to 60% of people who have, for example, a pneumococcal pneumonia will have some parapneumonic effusion. And generally about 30% of all pneumonias. Now, it only becomes a problem when the volume is much and when the translocation or the transfer of the bacteria or the bugs into the pleura is of such amount that you now develop Empyema or features of frank infection. The risk factors are many, but these are the main ones. Extremes of age, the very young and the very old. People who are debilitated, people who are very sick, people who have severe pneumonia. In some studies, actually in this study which I'm trying to show you there, I didn't write that down because most of Ugandans are rural. I can't say that being rural is a risk factor for Empyema. I'm a rural person myself, so I edited that out. But being rural, being disadvantaged, being poor, that means you seek care late, is one of the leading risk factors for Empyema because the infection continues unabated. There are other things like comorbidities, other lung diseases, bronchiectasis, rheumatoid arthritis, actually Dr. Pio mentioned about this, diabetes, congestive heart failure, and recurrent untreated GERD. If GERD is treated, it shouldn't really expose you to Empyema, but if it is untreated. And lastly, alcoholism. I think Dr. Joseph told you, our patient, if you can read this, the guy is 24, he has drunk enough to have pancreatitis, to have what else? Pseudocyst, and think some liver disease. I don't know where he will be at 40 years. But also, the important thing is, he also was exposed to a dangerous bug. I'm coming to that in a few moments. This patient is alcoholic, but also had a major surgery. Most likely, he had either a major aspiration or a micro aspiration. So meaning that if you aspirate, most likely you take in anaerobes and a mixture of other organisms. When you go to a normal clinic, general doctor's clinic, usually you have this pneumonia, what do they give you? A beta-lactam. So most likely this infection went on untreated because we know these anaerobes and other typical bacteria do not respond to beta-lactams, including cephalosporins. Now, to give you some example, this study was done. They involved 1,269 patients were included. They ended up with 92 patients with a complicated parapneumonic effusion or Empyema, and these are the things they found. Just to confirm the listing here. One, they found low albumin, they found sodium, platelets, and CRP. You can say actually these are features of people who are very sick. But also, they found that alcohol, was associated with an adjusted odds ratio of 4.28, but they also found intravenous drug use, which is not very common here, but is catching up. So that's why people get parapneumonic effusion. But there is another one which I have not put here. If people have pneumonia and you start treating them for 2 days, 3 days, you are actually creating empyemas. Please treat patients who have pneumonias adequately. Most of these empyemas are actually wrong diagnosis and wrong treatment.com. Just more evidence to show you, this is US data, it's not Ugandan data, how age, the extremes of age influence parapneumonic effusion and empyema. One thing which you can pick, this upper graph here, these are actually, if you look here, these are the people who are greater than 65 years. You can see they have a higher rate, and this rate has actually been increasing from 1996 to 2008. I actually don't know why the US could reduce all the other diseases and this one was going up. But just to show you that some of these infections, especially in people who are vulnerable, people who have diseases, people who are old and very young, they actually affect all of us. So the medical management, as I said, I promised that I would give some advice on how to choose antibiotics. One, most of these, like Dr. Rajan has told you, of these parapneumonic effusions or empyemas, they are caused by the same organisms that cause pneumonia. So this is the strep pneumoniae, which is the commonest thing. So therefore, you can actually treat them with the usual antibiotics, but in the right doses and for the right duration. Okay? Now, some of them are caused by anaerobes. And the risk factors for those, I have told you, are people who are alcoholic, people who have undergone surgery, people who are debilitated. They therefore need treatment for anaerobes. Some of them, especially alcoholics, they are very prone to Klebsiella pneumonia, which is a very dangerous pneumonia. They need to be aggressively treated. The other one is the gram-negative organisms. But we are going to come to that in a minute. Before we do that, sometimes I thought I should bring out this. The medical students ask us, someone has flank pass, you have pulled it out, you are seeing it. They take it to the lab, they say, no growth. And now everyone is confused. It says, how can pass, which we know is full of bugs, there is nothing which has grown. Now, from today, do not go and fight the lab man. I've given you some possibilities. One, if you did not take your sample very well, you will not be able to grow anaerobes from your pass, which you picked. Two, some organisms will not actually grow on conventional media, and therefore they are called, I don't want to ask you, I'm supposed to teach you, atypical organisms. Some of these are Mycoplasma, Legionella, and others. So they will not grow on your usual media. The other one is, you may have sampled patients who are already on many antibiotics. The other one, which is very funny, is that you can actually be tapping in a sterile component of the whole pocket. Is that possible? Yes. So if you tap to done, you don't get, please tap again. And like I've told people who have gone through pulmonology, if you tap your sample, you can actually also take a blood sample. Because like the chair told you already, some actually of these empyemas are hematogenous spread. So you can increase your catch. There are some new things which are being tried. One of them are the serological tests. We have serological blood tests for strep pneumoniae, for mycoplasma. You can actually apply them on your effusion with caution. And it has been shown that you can improve your diagnosis. Now, for antibiotics, I was going there faster. One, you can use all the other beta-lactams. And when we say beta-lactams, do not tell us now this is cefuroxime, now this is, which are the other one? Cefodox, whatever you are saying. A beta-lactam is the most important thing, whether it's a penicillin or a cephalosporins, you are actually talking about the same thing. So they will respond. However, do not give aminoglycosides. For some reason, Aminoglyoxal, they don't like a low pH, and in Empyema, the land there, they are inactivated. Meanwhile, we are injecting. For the gram-negatives, those are the options. I think I have to stop. For anaerobes, metronidazole, and for hospital-acquired organisms, we know that usually there's a high risk of MRSA, so please be aggressive with these ones, with the strong, should I say strong antibiotics? No. With a good choice of antibiotics. There is no role for injecting antibiotics into the pleural space just because you want to kill the bugs directly. Lastly, I can't stop Dr. Pio without talking about TB Empyema. I know Dr. Rajani talked about it. TB Empyema is very common for people who have gone through pulmonology. You know that many people can actually get a TB Empyema. What is the mechanism? The mechanism is actually the same. TB causes a pneumonia like all the other bugs. So if you have this tension within the lung and there is translocation, the bugs can actually translocate. However, in disseminated TB, especially in HIV, people who are old, people on dialysis, people who are malnourished, and people who have other chronic diseases, then you can have a TB Empyema. It is treated like all the other TB, but surgical management is very important in this TB because the complications are higher than in the normal bacterial TB. Thank you very much.